And it's going to be from Rachel Clark, who's from the Surrey and Sussex AHSN, and she's the partnership director. And yep, there's the slides coming up. Who's going to talk to us about the AHSN National Programme Prioritisation. And so,
thanks, Chris, and thank you very much for inviting me along this afternoon. It's been great to hear the conversations and to hear the fantastic presentations. So thank you to all those who presented so clearly. I'm going to talk to you a little bit about how the AHSN network prioritises its national programmes. I'm actually employed by the central team, but actually I'm a joint appointment across all 15 ARCs and all 15 AHSNs, and I've been working with the ARCs and AHSNs for about a year to foster collaborative working. So we initially did some work together at this that's still ongoing, that stemmed from the Beneficial Changes Network, and then you might be familiar with the NHS Insights Prioritisation Programme. So I've been partnering, working to facilitate that collaboration and supporting the ARC AHSN steering group as well. So I hope I'll be able to offer you some useful insights. What I think that we, like the ARCs, have been on a bit of a journey. So let me just move that on. So we were the AHSNs were established in 2013, and they are locally commissioned, or it's a national commission, but there is a local contract. So there is no network contract. We are 15 local AHSNs, and as our journey has progressed, there has been an increasing focus on what we do nationally, how we work nationally. So we have huge strength, like the ARCs, in being embedded in our local communities, having relationships with commissioners, academic, NHS, social care partners, industry partners, but we also have the national reach. So we're able to scale innovation at pace, really seeking to make sure that everybody has access to evidence-based innovations. So in 2017, the first national programmes were commissioned, and we have continued along that journey, and now have a strategy that was agreed last year. And some of the work I've been doing has been around writing the first business plan for the network, and that really focuses on the work we do together, not the local work. So it's very much about what the collaboration is and how we're going to resource that collaboration. And we've agreed new governance and an operating framework to support delivery of that. So this is just a slide. I'm not going to go into it in lots of detail, but you will have it as part of the slide deck, which gives a single capture of our network strategy. And what we're trying to do chiefly is to really increase the scale, scope and impact and pace with which we're able to spread innovation across England. So there are three strategic aims, and we've been doing work to build capabilities in those. I'm just going to give you a few highlights that relate to how we will choose our national programmes going forward. So this slide, this is taken from a slide deck we've done to share about our business plan. And I think the really important thing to highlight is that when it comes to our new national programmes, we will focus on the areas of greatest population health need and where there is greatest inequity in outcomes. And you will see listed there cardiovascular disease, respiratory disease, mental health, maternal and neonatal health. And I'm going to give you a bit of a whistle stop through why we've chosen those. And what I would say is that they are not set in stone. We will keep those under review. But the reason we've chosen to focus is because we have finite resources and we want to have deeper impact into some of these pressing health challenges facing health and social care. So we have gone down the route, and it's not easy to say that we are going to prioritise some areas, and that is a difficult thing, and the NHS typically is not great at prioritisation. So I'm just going to walk you through why we've taken those, we've selected those areas. And so this slide captures some of the main policy documents, and some have been referred to already this afternoon by colleagues. But over on the left-hand side is Core 20+5, and I'm sure you're familiar with that. But it is this really focused approach that NHS England and Improvement are taking to address the greatest areas of health inequality. So the core 20 is the 20% of the population that are most disadvantaged, and plus is some additional communities that need focus, that might be refugees, things of that nature. And then the +5, which is really listed here, is clinical priorities, where data tells us there is greatest inequity in outcomes for people who are deprived and from an ethnic minority background. And so there is a very strong call to action for people to get behind these 5 priorities in order to shift the dial. And when we look across those other documents, the long-term plan and the life sciences vision, you can see that themes resonate throughout, with the exception of maternal and neonatal health, which doesn't appear in the life sciences vision. But we see there is a good resonance across those policy documents. So when you're trying to prioritise, go where there's good evidence for prioritisation in some of those national documents, and we do want to be working in the space where there is greatest need. And so as an AHSN network, the determination was that initially we will focus on maternal and neonatal health. We have a strong track record in delivering improvements in that space through our Patient Safety Commission. We do a lot of work in mental illness and well-being. We haven't selected cancer. That isn't an area that the AHSN network has traditionally focused on, and is often a place where there's a strong focus on pharmaceuticals. So we haven't prioritised that because it doesn't play to our strengths and is often best served by other partners. Respiratory disease, we have a strong track record in, and our cardiovascular disease is very strong, particularly. So we've chosen those. So when we are identifying our national programs, they are the place that we start in order to select which innovations we are going to choose to scale and spread. So this next slide talks about some of the things that we're going to do differently that we haven't done before. So I've talked about those clinical strategic themes. We haven't deliberately chosen those before. We're going to conduct landscape reviews in those themes to really understand the health and care challenges, to use data to clarify the current state of play, to understand the policy context. So it's great to hear from Rachel and Annie, to really understand what matters to policymakers and to establish relationships in those key areas that are identified. We want to understand what other research and innovation in that field is ongoing, so that we really do understand who else is playing on the pitch. And we want to horizon scan for innovations and opportunities for innovation that will really make a difference in those areas. And then we will confirm those as strategic themes, so that we keep this as a live process by which we understand whether we're focusing on the right things. We want to convene a steering group around those clinical priorities, so that we bring together different partners. So we've heard from NICE this morning, and we collaborate strongly with NICE. But that steering group, I think we'll be looking to include ARC colleagues in that, to really help us to make the best decisions and to influence as strongly as we're able to. We're going to use an outcomes framework, which really drives our thinking, rather than just on what we can measure and process and proxies for impact. We want to really start by thinking, what is the outcome that we are trying to achieve by in these areas, and make sure that we are measuring as effectively as we can. And then for those priority themes, we will have a suite of innovations that, if applied along the pathway, will serve to deliver those outcomes. So it's quite it builds on work that we've already been doing, but takes a more systematic approach. And I'm not going to go through this slide, but this effectively, you'll have this afterwards to look at, to see the sort of stages in the process for what we're trying to do differently. And we've just wanted to capture some of the best practice that we've been doing around the network for some time. We've identified cross-cutting priorities, and you won't be surprised by those. So when we are thinking about our national programs, we'll always be thinking about what the digital opportunity is. How can we demonstrate improved patient safety in this approach? And always looking at that inclusion agenda. So I won't go through all of those, you'll know those. And this is what we're really trying to achieve. So along the left-hand side of this diagram, you will see a series of commissions. So we are commissioned by a number of different agencies. And what traditionally has happened is that those commissions have run in parallel. And so we've had these parallel pieces of work that haven't always intersected to make the whole greater than the sum of the parts. So what we're really trying to do by having strategic themes is to start to bring the different commissions into one place with a steering group that oversees and looks at the findings coming out and starts to say, how can we use this to support policy, to inform the next research set of questions, and how can we use it to influence what our health care providers are doing. So what this slide shows is how we will be bringing together the different programs that we're already doing. So all of these programs are already in flight, but we're starting to bring them under strategic themes. So we're managing them in a portfolio way. We already do this with the cardiovascular disease program. So we do have something that will help to guide us, but we haven't taken that approach in some of these other areas. And so the risk is that we're doing lots and lots of work, but without any coordination, without really being able to see what 15 AHSNs might be doing in the field of mental health, and bring that together and to do something more strategic with it. And the right-hand side of that diagram just generally captures what we do as AHSNs. Now, in thinking about how to make this a bit more relevant to you, and conscious that given this is a group of people who are very focused on aging, it may be discouraging not to see aging as a priority. And actually that's been a live conversation that we've had, because we have significant experience and expertise in aging. And that is not to say it won't come up as a theme again, but we are choosing to select some priorities. And of course, older people will figure in all of those. But places to collaborate. So obviously you will know that there is a relationship between a local ARC and an AHSN. So always engaging to understand what partners, what's happening. So for you, what is it that your local AHSN is doing? Can you work in collaboration with them to work out how to pull through innovations and get them ready for scale and spread and adoption? And we are increasingly looking at how we align our ARC and AHSN key priorities. So these platform programs that have been developed for ARCs and for our key clinical priorities, how can we bring those together so we understand the portfolio that is of research and innovation that's happening in those areas, and how can we use that? We have this pipeline you may be aware of, and of course this is a Manchester initiated event, and of course this stemmed from work that was done in Health Innovation Manchester to really start to categorize the stages of development of a given innovation, so that we take it from that discovery phase where we're really trying to test out whether this has got value, then testing it more widely to see what that looks like in a real world context, and then seeking to deploy that at a national level. And then that final piece is about sustaining the change. And so we are increasingly looking to visualize all of the 15 AHSN portfolios of work on a national innovation pipeline. So it will be a sort of national authoritative list of innovation that certainly that's coming through our networks, but we want to see how we can start to visualize some of the artwork on there, so we're really able to see how we can operate collaboratively and really drive innovation from the left to the right of that pipeline diagram. So and as I mentioned earlier, as we develop these strategic themes, we'll be looking to have ARC participation, so colleagues from ARCs with particular expertise sitting on those steering groups. So I wanted just to give that highlight. I hope that's a helpful overview. It's very timely. We, as I say, the strategy was developed last year, but we've just developed our first business plan, which is going through the final stages of approval. And that sets out a whole series of national programs that we are delivering across the 15 AHSNs, but also how we're going to develop some strategic capability to really deepen our impact in the biggest healthcare challenges facing health and social care today. So Chris, that is all I wanted to share at this stage, but obviously very happy to take any questions from colleagues.
Thank you very much. So I've seen a couple of questions in the chat. So I think Jane McDermott was the first question in there, commenting on age, or maybe ageism.
Yeah, so hi, that was really helpful to give a great overview of the AHSN, so thanks for that. I suppose my question, and you did sort of mention that obviously it's not just me mentioning from the Older People and Frailty Policy Research Unit, not just me mentioning age is both an inequality, there's an inequality in how we age across the life course, but also as a protected characteristic. And I feel quite strongly that actually, you know, including age in your narrative is a really important part of recognizing that, you know, we need to think across the life course all the way through into later life. But one of my questions is, you know, in mental health, you don't necessarily talk about age in any way, and that would be an opportunity. So why have you decided not to include age, I think is my question.
Yeah,
because I do think we need to talk about it. Yeah.
I think it's a really fair comment, and we've spent lots of time debating this, James, as you might well imagine. I suppose it's where's your starting point? If we're going to have a really deep impact, if we take, do you start with a clinical theme or do you start with a population group? That's kind of your starting point, really. And it is that question of prioritization. I was quite heartened. I don't know if any colleagues were able to join the Health Foundation learning event at lunchtime where Tim Ferriss, who's the transformation director in NHS EI, talked. I was quite heartened to hear him say that prioritization is a really tricky thing. The NHS is terribly reluctant to do it. And consequently, we end up trying to spread our resource and capability very thinly. So we have taken a decision to prioritise, and that is not always a popular thing. What we have done is also, though, develop an outcomes framework where for a given area, we are really trying to be clear what outcome we're trying to achieve for which population group. And so we've got 4 broad domains of quality, effectiveness, economic impact, equity. And we're looking at those to really understand what impact we can make in those. So under equity, we are really giving thought to how do we look at accessibility to innovation, what the uptake of innovation is like, and that might well get into age too. So we're trying to not have everything as a priority, but really take a very thoughtful approach then to where we're trying to have impact. And so age would, you know, be one of the factors that could well come into that framework around equity. So I appreciate that's not going to necessarily answer your question, and certainly I have colleagues who are not, would really like us to have prioritised ageing. So we've absolutely had that conversation. What I would say is these are not set in stone, and we are going to keep them under review to make sure that the AHSN is delivering as impactfully as it can in some of those main priorities.
Yes. I'm just going to reiterate it, because I do feel that you've chosen sort of 3 disease entities basically, and it's going to be doing more of what's been done before, rather than looking to the future and saying, well, aging is a really important area. We're all going to age. Our population is changing and has been changing, and it feels to me like I'm very much not just because I'm a healthy aging researcher, but because it's such an important component of what's happening in our society today. Anyhow, and you've gone for maternity and neonatal, so you can't say, well, we only segment it by disease entities, because you've actually taken a population subgroup there. So I know there are other questions in the chat, so I think Helen Roberts was going to follow through.
Thank you, Chris. So I'm also a bit disappointed, but we would be, because we're all aging. But one thing I would just like to ask about is that the ARC National Priority Programme had 8 areas, and then in the end funded 6. But apart from children and neonatal, children and maternity rather, they're on rather broader topics, like ours is also healthy aging, dementia and frailty, but there's also inequities and prevention. And I'm wondering, given the will, I think, of the ARCs and the AHSNs to work so closely together, there seems to be a dissonance between the ARC national programme and the AHSN national programme. And I suppose the other thing I was going to ask was, I wonder how long this current strategy is for, because the ARC national programmes will all complete towards the end of next year. And will your current strategy still be in place then, or are we not going to need to worry about AHSN national rollout for the ARC national programmes?
So let me try and disaggregate the components of that. So firstly, we have different commissioners, and hence we have we tend to have different priorities. So that does play out, and we've established that as something that makes it sometimes a bit more difficult for us to collaborate as we would want to across the ARCs and HSNs. So different collaborators, different priorities, and different timescales. So I understand the difference in the commissioning cycle for both ARCs and HSNs, and they don't coincide. And one of the reasons we have an ARC and HSN steering group is to work with our commissioners to have those conversations and say, can we have some really joined up thinking about as we go forward? And that the direction of travel has been increasing to encourage collaboration through implementation leads, who are mostly joint appointments between ARCs and HSNs. So there is a lot, so there is a move to increase that collaboration, and that collaboration happens locally, in ways that you will know and understand, and I don't need to go into, but we are trying to encourage and develop that. And through the NHS Insights Prioritisation Programme, where there was actually money to enable that collaboration, that's really being accelerated. So some think about that there are some things that are outside of our gift to address, but we do our best to overcome them. In terms of where there is discrepancy between priorities, you've got different drivers and different agendas. So commissioners of ARCs will make it's from NIHR, so it makes a different set of judgments about where to invest and where to prioritise. So that happens completely independently, as does the AHSN prioritisation process. And so what we are trying to do is increasingly find the opportunities to collaborate and bring them closer together. And we think that the conversations I was having with Nikki Cullum earlier this week and Gary Ford, the two leads for the ARC and HSN on our collaboration, is where are the areas where we could really start to focus some more collaborative work across our two networks. And I need to emphasize again that each of those 30 organizations are all independently commissioned with their own priorities that have been established. And then there is a national component that has to sit over it. So what we're not just trying to bring, you know, so the work I've been doing with the AHSNs is trying to bring together 15 organizations to agree on priorities. That's not very straightforward. You then double that to 30 when you bring in the ARC network, and that's not very straightforward. But we are on a journey and we are committed to collaboration. That is so much the DNA, I think, of who we are, ARCs and AHSNs. So it's a work in progress. Yeah.
Thank you, Rachel. Thanks.
Thank you very much, Rachel. I'm just looking to see if anybody else has got their hand up. Or is there any other questions? I'm sorry, I feel as if we possibly put you on the spot there a bit. Because we would say that, wouldn't we?
I did appreciate that coming in, that they may not be welcome, but of course they will impact significantly, some of them, older adults very significantly.
It segments the older adult population, segments it rather. If you ask me, and it makes it very medico-centric by going along a particular sets of disease entities.
It's always a set of choices, isn't it? And I think that's what we've had to reflect, is if we want to deepen our impact, we can't do everything. And therefore, how do we make the best set of choices? And what I would say is that those clinical themes, we are going to do the landscape reviews and make a final judgment as to whether they are the place where we should best invest our efforts. And so we may iterate a little.
Yeah. I mean, because when you said that these were the themes because they had programs and policy documents, etc., well, so do a lot of other themes, and those might be just reflecting the ones who shouted loudest and longest. Anyhow, it's been very interesting to hear, and I really do hope that we ARCs and the AHSNs will be able to work more closely together as years go by. And whilst Helen's completely right that the current iterations of the ARCs come to the end at the end of 24, we would hope that there'll be future iterations, if not mutations or variants. Let's not go there. Thanks very much for a very interesting talk. Yeah, thanks. It's very interesting. I'm just looking to see, and James thanked you for getting out an overview of the prioritisation process. Well, unless there are burning general questions from the floor, I would like really just to thank all our speakers today for what have been really very interesting, informative, and engaging. And made us think a bit, I hope made us think a bit about what we're doing in the ARCs and in our healthy aging themes. It's been very, very good and excellent session. So thanks very much. And I'm going to do a physical clap, even if everybody else does a very virtual one. So I have nothing.